Okay, welcome back, everybody. Justin Burr here, Department of Health Sciences. I'm with Jim Hutchins and Maddison Johnston, also here, back for our second episode here on our medical terminology podcast. Only med terms in the building. That we're gonna roll with that in the future.
Yeah,
I think that will work well. So here in Unit 2, we're going to talk about how we talk about the body. Okay, so how do we talk about the human body? How do we describe locations of things? Where are things located? How do we write about it, like clinically in documentation?
Patient signs and symptoms.
Yeah.
Right, all that stuff, right? We're saying, like, how do we just describe and talk about it? So a lot of these words will come into that aspect as we kind of go along. And I think the outline of the course here is we're going to talk about anatomical position, which is important for us to talk about locations of things, directional terms, and then SOAP notes for our clinical things. So I'll kick it over to Jim, probably to start. Jim, you want to describe anatomical position to us, what that means and why you think it's important?
Anatomical position is what we use in a clinical setting so that we're always talking about the same thing. For example, we can position patients so that their feet are higher than their head, but that doesn't make their feet higher than their head in anatomical position. So we use both anatomical position as a standardized idea plus the words that go along with that, like superior, inferior, superior meaning above when we're in anatomical position, inferior meaning below when we're in anatomical position. We use those terms so that we all have a common language, so we don't end up amputating the wrong leg, for example, which is a really bad medical error, which surprisingly happens
quite a bit. It says 3%. I was just looking it up because I thought that's where you were going to go.
Yeah. So easy to make mistakes if we forget about anatomical position. Anatomical position is exactly what we'd expect for starters, which is facing forward. So notice that when a patient is facing you, their right side is your left side. I always demonstrate this to students in the classroom by holding up my right hand, and that's going to be on the left-hand side of the screen as you look at that, because as you're looking at me, my right is your left, and we just accept that. But a surprising number of students, especially in the anatomy and physiology class, just because I'm cruel, I have a question in there where the right lung is labeled, and it has a numbered leader line going to the other lung, and it says, which lung is this? And a surprising number of people will say, right lung.
Even though it's still labeled on the picture.
Even though it's labeled on the other side of the picture, right?
Yeah, I mean, I talk about that a lot, too, in classes, just how easy it is when they're, especially early on, like they see this picture on the screen or the person in front of them, and their brain quickly says, well, that's my right, so I'm just going to pick a right. And I always say they got to take that extra second to make sure they flip it.
Yeah, I always tell mine, take a beat, take a breath, and flip it around.
Yeah, anytime you're picking right and left, I say you got to, early on, when you're getting used to it, you got to take that extra second.
And especially if you're going into radiologic sciences, then it's critically important. Now, anymore, most instruments, I think all instruments, mark the right and the left for you, like on an MRI, magnetic resonance imaging, or a CT scan, computed tomography, which are abbreviations that we'll get into. Perhaps. And they'll mark it, but still, when you're in the clinic, you don't have that necessarily marked for you, and you've got to make a mental note of that. The other unusual thing about anatomic position is that the palms are facing forward, so that my pinky, which is my ulna, the ulnar side, and it's going to be difficult to remember which side is the ulnar side and which side is the radial side, the radius and the ulnar, two bones in the arm. The ulna is medial, and that's the pinky side. And the way that I always tell students to remember that is I say, I would like some soup, and so in order to get soup, I have to supinate my palm. And so your palm is supine, your palm is facing the observer in anatomical position. That puts, if you try this yourself, if you're not driving right now, please don't do this if you're driving because you'll have to let go of the wheel. But if you're standing somewhere, then put your palms facing forward and you'll notice your pinky, which is also your ulna side, U and P in supinate, okay? Your pinky and your ulna are on the same side, which is the medial side. Medial is another word which means towards the midline. seems really easy when your instructor is up there talking to you and you're going, well, this is the stupidest thing I've ever heard. I would never get medial and lateral mixed up, and yet we know from giving exams to students that it's really easy to get medial and lateral mixed up. So spend some time practicing with yourself, your child, your dog, your spouse, whatever you have around, okay, and practice these terms and think about these terms. My heart is blank to my pinky, okay? Think about that, and that will help you with these terms because it's really, really easy when we're first using them to get them mixed up.
Yeah.
In time, it'll become second nature, but in this course, at the beginning of your learning process, it's really, really easy to get mixed up.
Yeah.
So that's anatomical position. If you don't want to remember that the ulna and the pinky are on the same side, then the other way to remember that is to go back to the 70s and say, that's rad, okay? That is so rad. And so rad is the radial side is what rad stands for, which is when I'm holding up my thumb.
Yeah.
That is lateral now when you're in anatomical position. So again, if you go back to standing up, looking in the mirror as though you're looking at yourself as a patient, then that patient, that imaginary patient, which is now in your mirror, is going to be with the thumb lateral. The radius bone of the arm, the forearm, is lateral as well.
Yeah, exactly. And I think you bring up a good point because directional terms are like the next topic, but they're really all one big story, right? Like we use anatomical, these directional terms to describe things in anatomical position, right? Because you were mentioning the thing that your head is always going to be superior to your feet, even if you're hanging upside down.
Yeah.
Even in Trendelenburg. Yeah.
Because we reference everything back to the anatomical position.
Yeah.
And again, I kind of make these points too, where most of the time too, the directional terms are in relationship to something else. We're usually describing something's relationship to something else.
Yeah.
Sometimes we'll use it to say like the pinky is medial, but that doesn't actually like get the meaning of the word. Like it's got to be medial to something, right? Like what's my reference point? Yeah, I think the other tricky one on here, and then we'll kind of probably move on to planes of section, also important in radiology. We're talking about images. It's proximal and distal, which I think gets a little bit challenging.
Big tripping point.
Compared to like superior and inferior.
Yeah.
And there we're talking about attachment points all the time is what I'm going with, right? Where I say like my elbow is more proximal. It's closer to where my arm attaches to my trunk than say like my wrist, right? Elbow is more proximal than my wrist. My wrist is more distal than my elbow, but it's attachment. We use it mainly for extremities a lot of time, but we can talk about other attachments. I usually try to point out like where the proximal end of the small intestine or something is like where it attaches to the stomach versus maybe the distal end is where it attaches to the colon, the large intestine. We have proximal convoluted tubules in the kidney and a distal convoluted convoluted. So we do use it as these attachment points. We're mainly talking about the extremity, but we'll see it in other places.
A couple others,
Yeah, we will. And when I'm explaining this in the classroom, I just indulge myself by referring to Monty Python and the Holy Grail, which was a formative movie for me. And so I say, where does the Black Knight get his arm chopped off? It's at the proximal attachment of his arm. It's a proximal attachment of the upper extremity, because that's a weird thing about arm and leg that we can talk about later perhaps. But anatomists use the words arm and leg differently than the rest of the world does, and that's something you need to be aware of too, especially if you take a real anatomy class from a real anatomist, because they just love to trip you up on this thing. But I say the cut, the sword wound is proximal to the arm which has been lopped off, in that famous scene from Monty Python and the Holy Grail where King Arthur confronts the Black Knight and cuts all of his extremities off and leaves him with just his axial skeleton and no longer has an appendicular skeleton.
But it's just a flesh wound.
It's a flesh wound.
So, and then the next one here and there too is we're going to go through our planes of section, getting kind of how we divide the body. Jim was referencing earlier radiologic sciences, because I think of that when I'm thinking about x-rays a lot, like, hey, this is like an axial view or a frontal view on an MRI or something like that. And I was even thinking back when, I don't even know if they do this anymore, I haven't had an x-ray in a long time, but like back in the day when it was not computerized and they had to like put those little right left
Yes.
yeah.
labels like down on the table right by you so they knew what it was.
Yep.
They had a little lead L or a little
Right.
lead R. It was
Right.
made of lead because it was opaque to X-rays.
Right, we need to know what that picture was
Yeah.
of the side. So,
Yeah.
so Maddison, planes of section.
Yeah. So planes of section, how we, just like Justin was saying, how we're dividing the body. So are we dividing the body in right and left, top and bottom? And one of the most fun ones that I think that we have in this unit is a sagittal plane. So a sagittal plane is dividing the body in right and left, but it comes from the root sagitta, which is probably going to be most familiar for a lot of our students as Sagittarius, which is a zodiac sign. And if you have seen the little, I don't know what the proper term for it is, but I'm going to call it the mascot for the Sagittarius. It's a half human, half man who is shooting an arrow. And so Sagitta means cutting the body, or the sagittal plane means cutting the body in right and left, but referencing an arrow. So if you were to shoot somebody with an arrow, it's going to cut them in right and
Big
left.
damn arrow.
Yeah, exactly. It's going to go all the way through you. So I think that's really interesting too, because it gives a little bit of context to something that students usually have a good idea of too.
And para as a prefix means next to. And
Yeah.
so many times we'll use what's called the parasagittal plane, which is parallel
Yep,
to the sagittal plane.
Yep.
And so there's an infinite number of sagittal planes.
Yeah.
The first one you're referring to, which is a very accurate archer, is the mid-sagittal plane,
Yeah.
if we want to get really ticky and technical about it.
Yep.
And all the other ones are called the parasagittal planes
Yep.
because they're parallel
Yep.
to the sagittal plane.
Yeah. Yep.
My favorite plane, and that only leaves one for Justin, and it's the one that's problematic, is going to be what you hear in the clinic and in the anatomy teaching lab, but you'll never hear officially, and it's not in our book, is a salami section.
Yeah.
And so we're imagining the human body in anatomical position as a salami. We're simplifying that human into a salami. And so if you slice salami, most people will not slice that lengthwise or what
Right.
we call longitudinally, but rather in cross section.
Yep.
And so a salami section is called variously an axial section because the body has an axis. If you can imagine the body rotating around, like a little wedding cake figurine, rotating around, then that's the axis on which the body turns. And when you cut perpendicular to the axis, that's called an axial section. The other name for that plane of section makes a lot more sense, which is the horizontal section, which is in anatomical position where the horizon is. So if you look off into the distance as you're looking at that body in anatomical position, you imagine a horizon cutting through that body. That's your horizontal section.
Yeah.
Now you get the one that sucks.
I was going with transverse.
Okay.
I'm not. I can do
The
coronal, but
transverse is another name for
That's
the
what I mean.
same
Another name. I always think
section
of like
thing.
the magic trick that we all saw.
Right, yeah.
Where they put the person in the box and
Yep.
cut them in
Yeah.
Cut 'em in
half,
half.
top and bottom. So, last one, frontal or coronal. And I think coronal is the more interesting medical term.
Yeah.
Yeah.
One, meaning like crown or garland,
Yep.
kind of in the background.
It's more
It
of a
has-
tiara, isn't it? It's not really, because I think of a crown as
okay.
being like
yeah,
a
circular,
crown of
but
thorns.
the tiara is a
or-
little bit
yeah,
more kind of upright. And that's kind of, I think, where the word comes from,
Yeah.
where we're going to separate anterior and posterior, front and back.
Yeah.
Sometimes people do that with frontal. They'll say front and back. Frontal
Right.
does front and back.
Right.
You can kind of link those words together in there.
And then the upshot of this is that, like so many times, and I always say to my students, I have a stock phrase. They say, there are three names for this one object or this one part of the body, and I didn't do it. And so
Yeah.
just remember that
Right.
none of us did this,
Yeah.
okay?
This is not our fault.
It's not our fault, but we just have to deal with it because
Yeah.
you don't know whether someone in the clinic is going to refer to the frontal plane or the coronal
Yeah.
plane. Those are names for the same thing.
You wanna know both.
Horizontal, transverse, axial are names for the same thing. Fortunately, sagittal just has the one name,
Yeah.
but we got mid-sagittal and
And parasagittal,
parasagittal,
yep.
but at least we don't have to learn a whole bunch of different names
Yep.
for that one.
Yep.
It's good. Next down the list on the unit is abdominal regions, which is kind of a fun one. I think mainly because, they can look them up and see them here in the book, but hypochondriac
Yeah.
shows up in here, which I
Yep.
think is a common word that we know about, something to talk about. Now I can give I'll give the actual meaning,
Yeah.
right? For like hypo And then chondriac basically means like the cartilage below the ribs. It's that cartilage that's connecting the ribs to the sternum, meaning just below there, right? This area kind of right in there. But then the term, a hypochondriac, has kind of come away from that. You know the history of that, Jim?
I do a little bit. I know that we were talking about in the last episode about how language exists within a context. And so this is something that exists within the context of Greek medicine, doesn't it?
Yeah. If I'm not incorrect.
You're never incorrect.
I know, that's bold. That's a bold statement.
As Davy Crockett said, I've never been lost, but I was once a mite bewildered for a few days. And so you may be a mite bewildered, but you're never incorrect.
More than a few days.
Okay.
But so if I'm not incorrect, they called it that because that's where they knew where the liver was. And if they couldn't find a better reason for somebody feeling sick, they would say, oh, it's the liver. They're just a hypochondriac.
Could be there too.
Yeah.
And I've always heard hypochondriac is like almost like the malingering type of a thing where if somebody who thinks they have every illness, they're describing this pain and these things, and if the physician doesn't actually believe that it's there, right, they got this term that they're a hypochondriac because this diffuse pain somewhere where there might not be anything to happen.
Yep.
I don't know if that's your...
Works for me.
Works for us. Okay. Continuing on down now. The last topic here in our minutes we've got left is about soap notes, and I think some words that we'll use in soap notes that have some interesting backgrounds. Now, a soap note is just a kind of standardized way to write medical records where the S, O, A, and P in soap note to stand for something, right? So the S would stand for subjective. Maddison, give us what subjective means.
Yeah, so subjective, how I kind of like to describe this is it is pertinent to the subject that you're talking to, right? So your patient is the subject, and it's things that I can't prove myself. So I can't prove that my patient is feeling nauseous. I can prove that they're vomiting because I can see that. That's objective. But subjective, that's something that they are telling me that I'm unable to test for or to prove.
Yeah, she just defined a term, Jim. What was it? Something they tell you.
It's a symptom.
Yeah.
So this is a symptom as opposed to a sign, and you'll find people in the medical profession who are really, really ticky about this, and so it's a good thing to learn to establish your credibility. So symptom literally means to run together, things that come together. Sim is prefix
Symphony.
we use for symphony. Okay, together. Okay. And so symptoms run together. And every child who's ever tried to get out of going to school knows you cannot fake signs. Okay, you have to go to a lot of work to fake signs. You have to put hot compresses on your head to give yourself a fever just before mom comes in and puts a thermometer on your forehead. You're gonna have to really time it well and make it work, okay? But anyone can fake a symptom. A symptom is something which you can fake, and that's the way that I remember the difference between signs and symptoms is, can I be fooled by the patient? And in that case, it's a symptom. And if I can't be fooled, then it's a sign. It's an objective test. It's the things which leads into objective part of it. These are tests which we can do that the patient can't fake. Now in PT practice, here's a good question. When I had a tear of my medial collateral ligament, that's the one that's medial in the knee joint, and so it's along the inside surface of the leg. It's collateral because it goes between the tibia and the femur. The medial collateral ligament, I had a tear, and the orthopedist did a test of my knee. And so if you do that kind of test, I mean, theoretically a patient could fake that, but you'd have to be a really smart patient to fake that. And so would you put that in the objective category? Would you put that in signs, or would you say that's a symptom?
Yeah, I mean, you put it in objective, any special test, I guess, in orthopedics, right? Yeah. The symptom that you're coming and you're telling me you got knee pain, right? You have difficulty walking, right? I might be able to then find some type of antalgic gait on my observation that could go in objective and say like, hey, they have an antalgic gait, which means it hurts when you walk, right? Fancy word for that. And then what you're describing, the test is called a valgus stress test, right? Where we put stress through, we take your leg into a valgus movement to put stress on the MCL.
Valgus is a good word for them to look up.
It is. It's probably in our word list, this unit.
I think it's in 5, but yeah.
Coming up. But yeah, so that would go in objective because you gave the symptom. I did an objective test, right, where I can say that test was positive or not. It's really no different than getting the thermometer. You say you feel warm. I might have a fever, and I say, well, let's take your temperature and see, right? That's you're telling me a symptom. I'm going to take a test of some kind and test that and see if it correlates, right? Like you said, if they run together.
I'm assuming the orthopedist then was able to feel laxity, which is another word, okay, the movement in my knee that shouldn't have been there because normally the medial collateral ligament is holding the knee together in a tight position. So with a valgus stress test, you're feeling the laxity, you're feeling movement that shouldn't be there in the knee joint. So yeah, that would I'll
Pain,
take that as
laxity,
objective,
all those things.
Yeah.
Yep. And really, you're gonna have to compare both sides. That's where it'll come down to,
Yeah.
right? And a test like that, you'd have to be like, well, let me feel your other knee, and see how lax or loose that ligament, how stretched is it, and then compare it back to the other side. So, which also has its. We're not getting the specificity and sensitivity here in this. We're going far there, but yeah. So I always go with those two. I like to point out another one is just vital signs.
Yeah.
That I get people to remember, right? Because it says signs in it. This is objective information that goes in the O part of a SOAP note. Like what was their respiratory rate? What was their heart rate? And their vital signs. It's called vital signs because those are signs. They're objective. They're measurable.
And vital because that means alive.
Right.
If they don't have vital signs, then they're alive.
Very much not alive.
One of my favorite medical jokes is a little routine about a patient who's asystole. And I've never seen this condition before. This patient has a condition I've never seen before called asystole, which we'll learn later on means they have no heartbeat.
Right.
So therefore they have no blood pressure. Therefore they have no vital signs. They're not alive.
Nothing to measure.
Yes.
I guess you could take their temperature.
You could, yeah, that would, but it wouldn't be a vital sign.
That's
it
true.
would be an Alger sign.
Yes, an Algor.
It would be an
I'm gonna do more.
algorithm, maybe. Ooh, you see what I did there?
Yeah, I like that.
Yeah. Okay. So. We gave them some words to look up now.
Yes.
Let's
I feel
just
like every
leave
word
it.
we say, I'm over here like
I know.
quick, like Frankenstein from the last ones. Every time we say a word.
Yeah.
So, A in SOAP is assessment, and it's basically bringing it all together. You're going to take their signs, what they're telling you, their subjective statements. This is what they're telling me. Here's the tests I could do objectively. Like what could I see? What could I measure? I'm going to bring that all together and make an assessment.
Yep.
Okay, that's kind of the most of the time. Well, I think we have diagnosis in this unit, saying like you might be your diagnosis in this thing. Basically, your educated thought of what you think is going on.
I'm an agnostic until I make a diagnosis,
There you
right?
go.
So I'm agnostic about this because I don't know.
Without knowing.
A is, we learned in the last unit, is a prefix which means not, and gnosis is knowing.
Yeah.
So Gnostic, like the Gnostic Gospels, if you get into that history, is the people who knew stuff. Okay, and not knowing is agnostic. And to separate what you know from what you don't know is a diagnosis.
Yeah.
And we come up with what's called then a differential diagnosis, a phrase you've never heard before, but which is used all the time. I would say every single day in clinical practice, you're going to hear somebody use the phrase differential diagnosis, which is that list of things which it could be. And usually providers, clinicians will put that in the order that they believe that things are. And a good physician or a good primary care provider, as they talk to a patient like me, they know that I'm fairly well versed in medical ideas. And so when you deal with those patients, you'll say, here's my differential. And they'll just go through the list and they'll say, okay, here's the two things that I think it is. And it could also be cancer, but I think that's pretty far down my list. Otherwise, I'm just going to be up all night Googling, whatever signs and symptoms I have and trying to find out what kind of cancer I have and whether I can survive it. But usually they'll say, look, it could be this, and so we need to do these further tests to rule this out. But what I really think it is I think you have dry skin because of calcium in your water. Okay, something really
we have dry air.
Benign.
It could be a basal cell carcinoma, but I think what it is dry skin.
Yes. And that always leads us into the discussion of like, when you hear hoofbeats, think horses, not zebras.
That's
right?
correct. Yes.
I use that one a lot, right? You're always start
And
with the most
definitely not
common.
a wildebeest.
Yes.
Yeah.
Very good. Last one is P for plan. So that's basically what you're going to do about it, right? So someone's come in, say it's Jim again, told us his knee hurts. He did this thing. We did our tests. Looks like an MCL sprain in the assessment. It could be a tendon or
It's
something
a
else
grade
that happened on,
it's
right?
Grade 2, so the fibers are separated but not completely.
Yeah.
So, yeah.
I was going differential, saying like, well, it could be, could maybe be like a. I always think like the pes anserine is right there.
Yeah.
Gertie's tubercle, which is just fun to say.
Yeah.
Where it's called the goose's foot, right? Pes anserine.
Yeah.
If we're going back for words, where like the MCL and the gracilis and these muscles and ligaments all attached right below the knee, right there on the inside. And you're like, well, if it hurts right there, like it could be any of these things. To your point, but here's the plan, right? We're gonna do this thing, or we're gonna do surgery. We're gonna do. I thought you were gonna say your injection or physical therapy or a referral to a surgeon or something like that. What am I planning to do?
Yep.
And for me, clinically, since we're talking about PT-related things, like these notes are just vital when anyone comes to me, especially if I can see their notes. Sometimes you can't see their physician notes, but if I can look up, hey, who's coming in? Like Jim Hutchins coming in today is on my schedule. It's not real. It's not a HIPAA violation. At least not for me.
Well,
comes
I
in,
think I
you disclosed it yourself.
Yeah.
There you go.
You know, he's coming to my schedule. And I can look at this doctor's note and I can see this real quick. And the outline of this is what helps me, right? Because I can look quickly and find certain information in certain places, like subjective, what happened, what test did you do? Did they not do a test that I might want to be considering? Like, oh, they didn't do that test, or maybe they didn't put it in their note.
Yeah.
But I'd be curious, maybe in the differential, I see their assessment. They're like, it could be this. I'm like, we didn't test for that.
Right.
Or maybe they did, right? But it just gives me the information that I need to kind of see what they were thinking. What's their plan? Were they going to follow up with that physician? How long were they anticipating them coming to therapy? So stuff like that can be very helpful if you can find it. If someone's not following the SOAP note,
Right. It's,
it's
a little
you're
bit
hunting in some endless paragraphs for something.
Yeah. Well, and I think too, clinically, even if you're not a PT or a provider and you're looking at specific SOAP notes, but having all of these things categorized in SOAP or even just S&O, you can call, and I mentioned this on the first episode, but when you call a physician as a nurse, you can call and you can say, hey, this patient has this going on and I don't know what we should do, but they're also reporting this and a vital sign says this, and you can have it just very disorganized, or you can call and you can say, this is the patient, this is why they're here, this is what they're reporting, this is what I'm seeing on vital signs. That's going to be much more helpful for a physician or for a provider to then say, okay, let's go ahead and do X, Y, and Z.
So I think we're going to go around here and just kind of pick out some of the cool words from the unit that relate to SOAP notes. We had a few kind of listed out that we thought were kind of fun that we would introduce, kind of their backgrounds and meanings. So Maddison, you want to start off with one?
Yeah, absolutely. So one that I think is interesting and relevant in my line of work or my specialty is a condition called Candida albicans. And if you break down albicans...
Candida.
Exactly. Thank you, Jim,
for that. Promise life will be sweeter. Take the monostat and you'll feel better.
Exactly.
Yeah,
and
like
that right there is the treatment for Candida albicans, friends. So Candida albicans, in layman's terms, it's a yeast infection, which we see a lot in gynecology. But albicans, alba... if you think about albinism or albino means white or whitening. And if you look into the root of it, it is white or glowing white. It comes from the same root as candle, which is really interesting. And when
that is an incandescent explanation.
Thank you. I know, you're telling me. But when the patient has Candida albicans or has a yeast infection, they have white discharge or glowing white discharge, which is a fun way to think about it if you want to get into the nitty-gritty. So if Candida means white and albicans means white, then
white,
glowing white, glowing white.
Yeah,
quite the description of some discharge for your
back to the thing of like, why would you name it? You know what I mean? Then you go back to the thing, you're like, white.
Yeah.
I always say sometimes too, this is kind of an aside. But I usually say, too, like, sometimes we think these words are really fancy.
Yeah.
Like, students think the words are so fancy because they're in other language, Latin or French. Like, they come from these things. But I'm like, I would say macrophage is my big example. Where, like, macrophage sounds fancy. But I'm like, no, they just said, like, that thing's the big eater. Yeah. Like,
you know,
exactly.
Cool name, Jim. You named it the big eater. Like, awesome. That was... Anyways,
or your foramen magnum.
Yeah.
Foramen magnum. You know what it means? It means big hole.
Yeah. They got real
it's the big hole in the skull.
Right,
okay,
like,
not the little holes. There's a whole bunch of other foramina.
One.
Speaking of plurals,
right?
There's a whole bunch of other foramina that are little holes, but the foramen magnum is the big hole.
Big guy.
Yeah. But I didn't even say it sounds really fancy, but it's really just the big hole. It's not anyways,
Going back to what they had, right? Just naming
Yes.
things off of what
that
they
looks,
had.
that looks like a big hole.
Yep.
Well, what should we call it?
Yeah. Big hole.
Excellent.
Yeah.
My favorite find from Unit 2 is the word alert, which is one of those rare medical English words that's neither Latin nor Greek. We have a very few from French. Jaundice is one of those, okay? I took French, so Mrs. Culp would be really proud of the way that I pronounced that. Everyone else would call it
Shout out
jaundice.
Mrs. Culp.
Jaundice, Jean. Okay, but jaundice is one, but this one is directly from Italian. And when we evaluate patients in the clinic, we will always evaluate their state of alertness. Are they alert? We say they are alert and oriented times 3, and that's to person, place, and time. And the place one is always problematic because I think the students think that they're going to examine patients and get like the GPS coordinates of their location, but that's not what we mean. We mean like, do you know like what this facility is?
Yeah.
Because if you have a patient who's not alert and oriented times 3, they won't know that they're in the hospital.
Yep.
I remember once when my aunt was demented, she was in the care home that was taking care of her. She had been in surgery, and she was in the rehab unit coming back from surgery. And my sister and I came to visit her, and my aunt said to us, "How did you know I was in London?" And my sister, who's not medical, and I kind of looked at each other, and we decided how to play this, which you always do with dementia patients. It's like, okay, do I correct her or do I just go along with it? And we made the, eye contact and decided, okay, let's just play along with this. And we said, well, we got all kinds of skills. We're amazing kids. We really know how to find you here in London, and But she thought she was in London.
Yeah.
That is not oriented times 3. She's not oriented to place. Alert means that the patient is interacting with you, that the patient is not laying on a bed, maybe groaning a little bit more when you pinch their toe or something like that. That is not alert. We have other words for that. But alert means that they're with you and that they understand the questions are being asked and they're responding quickly, because sometimes you can get a patient who will come up with an answer, "What's your name?" And they've been in an accident, they're concussed. And you'll say, "What's your name?" And they'll, Jim.
Yeah.
That's not alert. That's not a good sign. That's not something you want to see. So there's a sign there, by the way.
There you go.
Yes. And so alert means to the high tower, because it comes from when you were going to alert your troops. That there were troops, there were opposing troops coming across the plain, and so you were in a castle and you said, "To the high tower," and alerta means in Italian to the high tower. So that's where alert comes from.
Yeah.
So those beautiful etymologies that just is such a picture, and you probably already know what the word alert is, but I just had to throw that one out.
Yeah.
I do have what I'm calling one word, but I'm going to sneak in 4 because I'm the old guy here, and I can get away with these sneaky moves. Okay?
And then I'm going to steal one.
Yeah, you're going to steal one of them, and so we'll repurpose one. But so I have the first known medical mnemonic, at least that I'm aware of, which is, of course, because it's so old, it's from the medieval times, medieval medical school. They would teach you in Latin.
Medical school.
Medieval medical
I like that.
school.
The imagery in my mind of what that would look like.
There's a lot of cloaks in my mind.
I think they wore doctoral gowns while they were doing dissections in
Yes.
medieval medical school.
Yes.
Okay.
There you go.
So speaking of Dr. Frankenstein, but anyway, the first medical mnemonic that I know of or that I can track down is actually not by the first letters, which is what we usually think of with mnemonics, and Mnemos is the Greek muse of memory. But the first memorization device actually was a rhyming mnemonic that's Rubor, Calor, Turgor, and Dolor. And those are the 4 cardinal signs of inflammation that we now know as redness, heat, pain, and swelling. I don't think I got the order right, but we'll get to that in a minute, okay? So rubor is redness. Same thing you get if you rub something and it turns red, okay? So rubor is redness. Calor is the one that I want to talk about, which comes from caloric, which is a kind of test that you can do of the inner ear using hot water, or calorie, which is what you burn when you're burning your food. It's a unit of heat, okay, and it means heat. So calor is a word that you know already, you just know it in a different context, and that's heat. And so redness and heat are two of the four cardinal signs of inflammation. By the way, inflammation, the suffix we learned in Unit 1, because I would say it's the most used medical suffix of all. Yeah. It's in every unit we have this suffix, and it's itis. So anything that's an itis has as part of that redness, swelling, heat, and pain.
Yes.
Pain. What pain? Which
Yes.
one of those words is pain, Justin?
Dolor.
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 Okay.
Is what we'll take. I was actually going to go on itis and say that's like the second favorite.
Are we going to do the Seinfeld version of this as well? Because
With
I
Dolores?
really set you up for that.
It's even in the book.
It's even in the book.
Linked.
Yes.
No.
Why would somebody do that?
Yes, because it rhymes with part of the female anatomy.
It does.
That's why. Anybody got to watch the Seinfeld episode?
Mulva, is that the word?
Well, that one does also, but that's not her name in the
Okay.
Seinfeld episode. Although I did name my GPS that.
Yes.
Like the person that talks to me in my car.
Oh yeah. Well, naturally.
That way, when it goes the wrong direction, I can blame Mulva.
Mulva.
But,
Mulva.
anyways, yeah, on dolor, right, those things, because it means pain, but it also means sorrow, right, could be there. So I found that one interesting. That's kind of the word I was picking on. That dolor, meaning that, it kind of comes back from, again, sorrowing, and it really comes from Mary, right? So Mary of the Sorrows is what it's called. So that her 7 sorrows that she experienced in her life with Jesus and those things were like having to go to Egypt and watching the crucifixion and the burial and those types of things, right? These were the 7 sorrows.
Yep.
And the name Dolores, right, actually comes from that meaning, which is kind of interesting, right?
Yeah.
So, and Dolores, back to Seinfeld, right? Her name was Dolores.
Yeah.
Her name was
Also
Dolores,
rhyming with part of the
which
female
he
anatomy.
wished he had known about 15 seconds earlier.
Well, before he made out with her.
Yeah.
Because
Before he made out with her.
you can't
Yeah.
ask someone's name after
No.
that's happened.
I
According to
have
the
found
episode.
that to be true in my own personal life, is that the time to learn someone's name is
Beforehand.
before
Or you will go
invite
away.
them to your apartment.
I wonder if they went with sorrowful or painful because of that in the episode. Because
Maybe.
I think they just liked the kind of sly reference to a
Right.
part of the female anatomy, which
Yes.
they were not allowed to say on TV. So
no,
you have to
I don't
supply
think we're allowed
that.
to say either.
No, we're
No.
not, and we're not going to.
Not until
but-
reproductive. Then it's
Right.
Fair game.
yes.
Okay. Yes, Dolores.
Yes.
Yeah.
Yes.
What
So-
a podcast to talk about Jesus and Seinfeld in the span of 45 seconds.
And
huh?
profane.
Yeah.
They're just
Yeah.
agnostic.
Really full
And
of them
alert.
today. Yeah.
They-
Yeah, we're
now
getting all
they're
these words
alert.
in. So
Yeah.
Now they're paying
Yeah.
attention. Okay.
good. My other one was Insidious, which could kind of go with alert, I think, I guess, a little bit, right?
Right.
If Insidious is in there. I think there's a movie, Insidious.
Yes. Yeah.
I've never
Horror
seen
movie.
it.
It's
Yeah, because
terrifying.
yeah.
I've seen it.
Have you seen it? You have
No,
seen it?
I've not.
Yeah, that's not my brand, I don't think.
terrible. It's not
I
my
go with my
brand
Big
either.
Fat Greek Wedding
Okay.
Yeah.
style.
No, my brand is Below Deck. That's my brand.
That's a good one.
Yeah, but
Okay.
Insidious, because we'll use it to describe like a disease that's kind of come on slowly and didn't like make itself known like really quickly. Because Insidious, the term, right, from the Latin,
Yeah.
means deceitful, cunning, artful, treacherous, right? It's this kind of,
Sneaky.
again, snuck up on you type of thing. It's a disease that just kind of over time
Yeah.
kind of entrenched itself, right? Versus like an acute onset, something
Yeah.
that was like rapidly came right on. Like the start date. In the PT world, I'm like, when did this happen, Jim? When did you hurt your knee, and
Right.
when did that start? And you're like, well, last Tuesday when I was running,
Right.
Like we have a date. But if he was like, I don't know, like over the last
Yeah.
2 or 3 years, my knee has just kind of gotten worse. That's
Right.
kind of like it's kind of snuck up on him,
Yeah.
right? It's been not really an event that we know. It's insidious onset.
So the opposite of insidious is ictal, which
yeah,
is a word
ictal.
you'll only hear in medical English. It's not in very common use outside of
Right.
the clinic, right? I was trained by a neurologist who made that point, that he said the way you can see the presentation of a stroke, a cerebrovascular accident, is that a patient will, if they're reporting just a normal headache, everyday headache, they'll say, you'll ask them, when did this headache start? And they'll say, oh, this morning I woke up feeling not so good, and then by lunchtime my head was pounding. Yeah. And that's an insidious onset. Right. That's slowly creeping up on you. But when they have a stroke, the onset is ictal, and they will say,
seizure.
I was a seizure.
I mean, that's what the word we use for
is a seizure. Yeah. And so we'll call this an ictal onset, that the patient says, I was pouring my morning coffee and the cup was half full and I had this blinding pain behind my eyes. Yeah. That is not a normal headache. Right. Headaches don't come on like that normally, and that is a headache that's indicating something serious wrong has gone bad, and it'll get you to call 911 or get someone around you to call 911.
Alert you to call 911.
Yeah. Speaking of movies, though, she did a wonderful job of depicting an ictal onset in the movie Contagion. Yeah. I believe is that?
I haven't seen that one. I have Jim looks. I have a 2-year-old and a 5-year-old and an 8-year-old, and so, if it's not Moana or Paw Patrol or
Madagascar, which you brought up last
Madagascar is a good one.
Yep.
My 2-year-old went down the stairs singing, "He likes to move it, move it, move it." Back to Jim.
In the movie Contagion, Gwyneth Paltrow depicts an ictal onset. I just want to say that the movie Contagion I can't watch since the pandemic because it has a vision of a pandemic, which turns out completely differently than the actual pandemic did. We mobilized the Centers for Disease Control, and they come up with a vaccine, and everybody wants the vaccine, and so people are lining up for the vaccine. But they have to have a lottery system for the vaccine, and so there are army trucks which are bringing in army troops that are trying to keep people away from the vaccine, okay, so that they can't go out of turn because they've got to take their turn for the vaccine. But in that, the disease, which Gwyneth Paltrow is patient 0 for this disease, she's depicting an ictal onset, and I want to say it's one of the best depictions of an ictal onset of a disease, and we've all seen this since we've been in clinical practice and we've been around clinical practice. But it's that horrifying look that a patient gets on their face when something goes wrong inside of them. And sometimes they can't even tell you what it is because they become aphasic. They are unable to speak is what aphasia means. But they just have this look on their face like, oh my God. Oh my God, I've never been here before. We haven't talked yet about ia being a suffix that means disease in another country, but they have instantaneously been transported to a place, another country, an ia, like Bulgaria or Romania or Czechia, where they're in a different place, and you can just watch it in their eyes when they occupy that different place. It's like, oh my God, where am I? This is not something I've ever felt before. This is not something I know about before. This is, and it's terrifying as a medical worker. You have to cover up the fact that you're terrified by it. But it's the scariest thing I've ever seen, and she just nails that look on her face. I think it was the direction, because Soderbergh is a great director, but just where she just looks like,
that impending sense of doom.
That hard to describe thing, right? Like that's in there.
Just before she goes into a seizure, she has her ictus.
Yes.
And so she goes into a seizure because of brain swelling.
Right
because of,
So more on neuro in the neuro section.
There we go.
So that was my list.
Yeah. Mine
Anyone
too.
have another one?
No. We got it.
So I think we locked it up there for Unit 2, and we'll uncover some more topics in our next one.
Yep.